Our second presenter this morning is Dr. Emily Hielscher. Emily is an experienced and passionate mental health researcher working for over 10 years across different academic and NGO settings, a PhD in the field of psychiatric epidemiology, and she currently works as a senior mental health researcher at Flourish Australia. Emily also holds honorary lecturer position with the University of Queensland and affiliate scientist position with QIMR, Berghofer Medical Research Institute. And today, Emily will be speaking to us about the Australian Youth Self-Harm Atlas. I hope I've covered all that. Thank you. Over to you, Emily.
Excellent. Thank you so much. Thanks for having me this morning. So let me share my slides. Hopefully everyone can see that. Please shout out if you can't, because that'll be not a good start to the day. So thanks very much for having me here today. I just firstly wanted to acknowledge the traditional owners of the lands on which we meet today and pay my respects to elders past, present and emerging. I also want to acknowledge all those who've been touched by suicide, including carers and families. So I'm really delighted to provide a very high-level overview of this project, the Australian Youth Self-Harm Atlas. So this was a mixed methods project of spatial modelling and mapping, and it was funded by Suicide Prevention Australia Innovation Research Grant. So this was really my baby for the past 18 months. And as I said, this will be just a very high-level summary of the findings today. And really at the heart of this project is the idea of sense of place, where sense of place is really critical for one's health and well-being. So this project started in early 2021 and finished in about June last year. The project team, as outlined here, include a partnership with Roses in the Ocean, who is a leading Australian suicide prevention NGO, along with project co-investigators at ANU, Curtin University and QIMR Berghofer Medical Research Institute. And yes, this project really was driven from a need to better understand this shift in suicide prevention policy in Australia from a national approach to one that's really regionally tailored and responsive to local needs. So we know that this approach is supported by a number of previous studies. However, there are still some large gaps in this literature where studies have largely focused on suicide deaths or hospitalisation records alone, which may not properly reflect prevention needs. Also, few studies have presented on national data of young people, which we know is a high priority population for suicide prevention. So yes, the Youth Self-Harm Atlas attempts to address some of these gaps and priorities. And to our knowledge, this was the first study at the national level to investigate regional variability in self-harm in Australian young people, including non-suicidal self-harm and suicide attempts. So this was achieved by analysing a nationally representative youth survey to produce local level prevalence estimates, as well as by conducting focus groups with young people living in geographically diverse areas in order to hear from them in terms of what they believe should be key priorities for prevention initiatives in their local area. So unfortunately, I won't have time today to present on the focus group component of this project. So I'll just be focusing on part A, where we investigated regional variation of the prevalence of youth self-harm. So to achieve this, we employed small area estimation techniques, which in short involved predictive modelling of nationally representative youth survey data and census data provided by the Australian Bureau of Statistics in order to generate synthetic self-harm prevalence estimates, ensuring we had an estimate for every region of Australia. and then mapping these estimates across the nation and statistically examining their spatial distribution. So I'll break down the data sources and analyses in a bit more detail. So the main data set used for this analysis was the Young Minds Matter survey. So this was a national household survey led by the team at the Telethon Kids Institute in Western Australia. So the target group for the survey was Australian children and adolescents aged 4 to 17 years. And the questions specific to self-harm and suicidal behaviour were collected directly from young people aged 11 years and over via a self-report survey. And so the questions asked to young people are on the slide here. Okay, so in addition to data from the Young Minds Matter survey, we also incorporated sociodemographic data from the 2016 census, which was built into our small area estimation modelling, which I'll get to in a little bit. And then all final prevalence estimates for this project were updated to 2019 using resident population data from the Australian Bureau of Statistics. So the Young Minds Matter survey data has been geocoded at various spatial units, allowing for us to conduct these analyses focused on regional variability of youth self-harm. So this is just a brief overview of the analysis that was conducted by our team, which involved descriptive steps, such as visually inspecting distributions and spatial patterns of prevalence of these self-injurious behaviours and their related risk and protective factors. This was followed by predictive modelling and generation of synthetic estimates to ensure we had an estimate of self-harm prevalence for every region in Australia. And this predictive modelling step was particularly important for this project, as the Young Minds Matter survey did not collect data from every single community in Australia. So to be able to map self-harm estimates across the entire nation, we really needed to create a synthetic model to extrapolate the survey data to other non-surveyed communities based on auxiliary census data. So this is known as small area estimation, where in short, we took variables common to both the survey and the census data and modeled their relationship with area level self-harm in order to calculate predicted prevalence estimates for non-surveyed areas. So just keep in mind what we're presenting are synthetic, not direct estimates of self-harm. And these are produced from modelling data from those multiple sources in order to produce estimates for more granular populations. And these, of course, come with their own set of assumptions. Okay, and then the final step of our analysis involved mapping those estimates across the nation and then statistically examining their spatial distribution and patterns using various techniques such as hotspot analyses. So most analysis steps were conducted at the lowest geographic unit possible, so i.e. statistical area level 1 or SA1. And then these were rolled up for mapping purposes. And so data was visualised at the SA2 level and above, which is essentially the size of suburbs within cities. And SA2 and above are geographies commonly used by or of interest to service planners. And then a very final step of our analysis was validating our synthetic self-harm prevalence estimates with SA2 level suicide death data from the National Mortality Database. So this is actual data, not synthetic data, of suicide deaths in smaller areas across the nation. Okay, so in terms of the key results, it's really important to first emphasise that these results focus on young Australians aged 12 to 17 years and focus on our primary outcome of self-harm, irrespective of intent in the previous 12 months. We also did some additional modelling on our secondary outcomes of non-suicidal self-harm and suicide attempts. So in terms of the key take-homes from this analysis, we found large variability in youth self-harm prevalence across Australia, furthering support for the government's regional approach to self-harm and suicide prevention. In terms of overall state prevalence, the key states with the highest estimated prevalence for youth self-harm were Northern Territory, Western Australia, and South Australia. And in terms of level of remoteness, there was an overall trend of increasing youth self-harm prevalence with increasing remoteness for both primary and secondary outcomes. In terms of key variables in our predictive models, at the individual level, psychological distress and depression were key, both self and parent reported. And at an area level, Indigenous status, parent employment status, socioeconomic indices, as well as country of birth were important. And in the final area level model, the strongest predictor of youth self-harm was percentage of single unemployed parents, whereas areas with high percentages of families with parents born overseas was associated with markedly reduced odds of youth self-harm. Okay, so here is the mapping outputs for those synthetic self-harm prevalence estimates at the SA2 level across the nation. So these were produced using the ArcGIS mapping software. So in these maps, dark purple indicates high prevalence, i.e. areas in the greater than 90th percentile, whereas very light blue indicates lower prevalence of self-harm. So you can see here on the slide that regional parts of Western Australia and Northern Territory indicating elevated prevalence. We can then zoom in on different sections of the national map for more city and town level data. So for example, here is the wider Brisbane area where notable pockets can be found in Brisbane South, Logan and Ipswich regions. And here is Perth, where pockets around Rockingham and Armidale are showing elevated prevalence of youth self-harm. We've also been able to map outputs at other spatial units to really allow for flexibility in the presentation of the data. So this includes SA3, as well as primary health networks. So here on the screen, we've identified the primary health network, or PHN, with the highest estimated self-harm prevalence in each state and territory. So the team has also conducted some self-harm clustering analyses using the ArcGIS hotspot analysis tool. So this tool pinpoints locations of statistically significant high value and low value clusters of youth self-harm prevalence in the greater than 90th percentile. So here we're finding significant clustering across metro, regional and remote parts of WA, Northern Territory, Northern and Central Queensland, outer Western Sydney, and certain parts of Melbourne and Adelaide. Of course, this type of spatial analysis can only really provide an indication of what may be happening at the local level, which is why we really need more real-time monitoring data in these areas. And finally, the team has also started to explore how area level associations between youth self-harm and key risk factors changes across the nation. So this has been achieved using bivariate choropleth mapping tools in ArcGIS. So this bivariate mapping has shown that for all factors, associations with self-harm differed geographically across Australia in size and direction. So this included social determinants, as well as psychological variables, such as internalizing disorders or depression anxiety disorder prevalence, which shows a strong positive relationship with youth self-harm in many, but not all areas of Australia, as indicated by the dark blue areas on this slide. So this is just preliminary, but does further highlight the complexity and variability of the relationship between self-harm and mental disorders. The same was found for economic factors. So we found overall a strong negative association between self-harm prevalence and socioeconomic advantage across the nation, as indicated in dark pink on this slide. For some metro areas, however, these relationships were reversed, where high socioeconomic advantage was associated with high self-harm prevalence in most capital cities, as indicated by the dark blue regions in the zoomed-in map of Adelaide. So these bivariate maps are available in the published paper and in the online dashboards, which I will present in a little bit. So of course, this work has its limitations and caveats, and at this stage, we're just doing the best we can with the data that is available. So synthetic estimates are the best available small area data that can be used for service planning. However, a key limitation is that these are not direct estimates, but rather are based on a model with a set of assumptions. So where these assumptions are violated, model predictions may not be accurate, and it's really not possible to test these assumptions without detailed small area data on actual numbers of self-harm cases, which is obviously not currently available to us here in Australia at the moment. And we would need to do something like a census of self-harm in order to obtain actual small area data. The other limitations to keep in mind include low survey coverage in certain states and territories and aging cohort effects. So both of these aspects may impact the accuracy of our estimates. Okay, so I just want to end the presentation by taking a quick tour of where the project's data and maps now live, which is on the Australian Suicide and Self-Harm Monitoring System website. So for those who are not familiar, the monitoring system is a publicly accessible data portal, and it's really our most comprehensive collection of Australian data focused on self-harm and suicide. And it's a huge credit to the team at the Australian Institute of Health and Welfare, including Chris and Lucy, Rosalind, many others, for their extensive efforts with collating and managing this data portal. So the portal informs the general public about nationwide prevalence and spatiotemporal patterns. It also helps guide policymakers and service planners in terms of how to best prevent these behaviours and how to best support those who are impacted, including identifying areas and communities that are particularly vulnerable. So the Youth Self-Harm Atlas has now been added to the portal, where our team has, mapped the prevalence of youth self-harm across the nation, identifying areas of low and high risk. So this includes an interactive dashboard of maps focused on youth self-harm prevalence in the previous 12 months. So prevalence estimates are currently being visualised on the public-facing website, ranging from the SA3 level, which is just above suburb level, through to SA4, PHN and state level. The website also includes prevalence estimates for our secondary outcomes of non-suicidal self-harm, suicide attempts, and suicidal thoughts or planning. So this can all be accessed via the website at any time. On the website, there's also a separate dashboard of maps focused on those associations between youth self-harm and key factors such as internalising disorders and socioeconomic status, and visualising how the relationship with youth self-harm changes across the nation. And associations are presented at the SA3 level on the website. And these bivariate maps really help emphasise the point that there is geographic variation not only in the prevalence of self-harm, but also in the nature of self-harm's relationship with key risk protective factors, and that some factors might be more relevant in certain regions than others, and that this really needs to be taken into consideration in local level service planning. It's also worth noting that AHW offers limited access to a separate analyst portal, which provides more detailed access to self-harm and suicide data on the monitoring system website for service planning and evaluation purposes. So access is currently limited to appropriate government and non-government service planning and provision organisations. So, for example, primary health networks should have access to this portal. So access can be submitted, so you just submit a form online via the website, and then the team will review your application. So the Youth Self-Harm Atlas data is also available via this portal at the SA2 level and above, and it also provides just more detailed outputs around those bivariate maps and our hotspot analyses. So just to wrap things up, I really just want to highlight 4 key take-home points. So first, the Youth Self-Harm Atlas really strongly supports a highly localised approach to prevention strategies in Australia. So the study's small area spatial mapping and focus groups found substantial variation in the prevalence and experience of youth self-harm across the country. So in particular, Northern Territory had the highest estimated self-prevalence of youth self-harm, and hotspot analyses across the nation identified local areas that may require increased resources, supports, and real-time data monitoring. The Atlas study also supports a holistic approach to youth self-harm and suicide prevention approaches. So our modelling showed that youth mental illness was a key factor, along with parental unemployment and socioeconomic disadvantage. And programs and policies really need to build in a holistic, multi-level understanding to preventing engagement with these behaviours. As discussed today, the Youth Self-Harm Atlas data and maps is currently available on the public-facing monitoring system website, along with a comprehensive collection of other Australian data on self-harm and suicide. And finally, small area estimation modelling, can be a really useful tool for governments and service planners, where it can produce estimates of self-harm or other behaviours at geographies not typically available, or for data desert areas where actual data is just currently not being collected. So small area estimates can help guide more localised service planning across the country, whilst keeping in mind, importantly, the limitations of this type of modelling. Okay, so that was really all from me. I just wanted to say really big thank you to my team who works tirelessly, as well as our funders, partner organisations, and wider collaborators. And most importantly, a big thank you to the thousands of young people who participated in this work. Their contributions via surveys and focus groups were absolutely critical to the final published work. So very open to take questions now, or please email me using the contact details on the slide. I've also provided the contact details of AHW's monitoring system team in case anyone had broader inquiries about the platform. So thanks very much.
Great. Thank you so much, Emily, for a really informative and invaluable resource to inform suicide prevention strategies. There is a question in the Q&A, which you did touch on towards the end, but I'll work through it. So
Sure.
Since the release, are you able to provide any updates on the recommended next steps identified in the Atlas? So partnerships with key stakeholders, research and programme planning focused on improving youth mental health, e-safety discussions, education programmes, discussions with PHNs and service planners?
Yeah, no, thanks, Chris. A number of recommendations came out of this work. As you can imagine, it's quite a broad piece of work, but I think the key things we're really trying to take forward is really honing in on where we need to set up more rigorous partnerships with stakeholders in those areas identified in the clustering analyses, and really strengthening kind of data monitoring kind of exercises. As you can imagine, it's still quite limited in terms of what we're doing at the moment in terms of real-time monitoring across the country. So that's really a strong focus. The other aspects are really kind of continuing to push forward the piece around, yes, youth mental health only explains so much of these behaviours. It's really that multi-level sort of understanding, and policies need to be reflective of that. So really some advocacy pieces around that. And then, you know, something that really wasn't covered probably in depth today, but really what came out of the focus groups more strongly was, yes, e-safety considerations and considerations around more recent environmental stresses. And that's currently, as you can imagine, it's not well reflected in the larger nationwide kind of data sets that we have. And so I think this is the strength of doing like a mixed methods sort of project. We really were able to capture in those focus groups that, okay, these are some of the actual additions that we need to keep in mind in, around e-safety in particular. And so the e-safety commissioner has seen this work, and we're currently in discussions with them about this.
Thank you. Do we have any further questions online? Don't have anything come through. Just checking the chat. No, final call for questions. You've escaped here, Emily.
I know, you guys left it easy for me, but as I said, very happy to take any questions afterwards. Just please send me an email. And I think the monitoring system website, I think, is such a fantastic resource. There is so much on there. Like if you go there after today and have a look, like it's just almost overwhelming, like how much data and resources there are there. And as I said, the team is happy to, where appropriate, provide much more detailed kind of access to data required for service planning and evaluation purposes. So I think it's almost underutilized at the moment. I think there's really an advocacy piece around that data platform in itself. So just please reach out afterwards if there's anything else that came up after today.
Right. Well, thank you so much. Thanks for sharing your knowledge, and thanks for being a part of today's conference. We'll now take a short break, and we'll recommence at 10:50 for the next presentation. So thanks, everyone.